Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Good morning and welcome to the PCRF Clinical Journal Podcast. We're thrilled to welcome you this morning, this lunar day, if you will, as we embark upon talking about research and probably throw in a few eclipse jokes. Thrilled to welcome everyone today to join us as we talk about a national assessment of EMS performance at the response and agency level. I'm joined today by Dave Page, Dr. Tony Fernandez, Jeff Rollman, and we are joined by the lead author of this paper, Dr. Michael Redlener. We're thrilled to welcome him as he talks us through the paper. As a reminder, this podcast will be joined with an article that's written in Journal Watch. This is paired with EMS World. If you navigate to EMS World and search education, you'll find our monthly podcasts are posted there. I think no better way than to welcome you all with an eclipse picture. So if the eclipse is occurring in your time zone currently, you've now seen it. And there we have a very pretty eclipse. Remember, don't stare directly into it.
I feel completely in the dark. Now, here comes the light.
Well, I think this, what a great segue into research, Dave. Thanks for joining us this morning. Again, we're really going to key in onto the research, but as well recognize that some of you may be running outside to look at the eclipse. Remember to wear your lunar glasses and don't stare directly into the eclipse. I can think of no better way than to start into the introduction and welcome Dr. Michael Redlener to us. Do you want to provide a brief introduction? And Andy's got his eclipse glasses on.
All right, I couldn't see anything. It didn't work on the screen here, but thanks. Thank you for the introduction. It's not we're not under the eclipse quite yet in New York, where we have another couple of hours, but I'm pretty excited to run outside when it happens. Michael, thank you so much. I'm Michael Redlener. I am an EMS and emergency physician in New York City at the Mount Sinai Health System. I wear a few hats in my life. I'm the division director for EMS and disaster preparedness here at Mount Sinai, and I also serve as the president of the National EMS Quality Alliance. And so we're here to talk about our article as you introduced the National Assessment of EMS Performance at the response and agency level. And what I can tell you about the reason and the rationale for writing this article was really it starts from when I first became a medical director out of my fellowship. And, I was looking for ways to understand how our EMS service was doing a good job and taking care of patients in the way that we wanted to. And there was it was just at the beginning of electronic medical records for our service. It was like trying to understand the data that was coming out of our what we recorded in our patient care. And there was a lot of information, but not a lot of ways to kind of understand clinically about how we were looking at the care that we were providing, and looking at data over time to understand how patients were doing. And so that kind of started my journey into measurement and thinking about how we measure quality in EMS. And at the time, EMS Compass was starting, and it was a project to define quality measures in EMS. And so I got interested in that, and that was something that really kind of took my interest. But as we all know, it took a little while longer to kind of get to the existence of national quality measures. And at the National EMS Quality Alliance, and with support from NHTSA and from other many organizations, we were able to kind of organize these standardized quality measures for clinical quality and safety in EMS. And we've been working on those for some time. But the reality was that there's not a lot published papers on a national scale of that quality. And this paper was really an effort to kind of take the national measures, take the national standardized quality measures from NEMSQA, which you can find at nemsqa.org, and match them with the NEMSIS data set, which is the largest EMS data set in the country. It's got representation now from I think at the time it was 47 or 48 states, and now it's up to 53, I believe, states and territories of the United States. But we wanted to look at the kind of broad picture of what was happening related to specific quality of care for patients in EMS. And so that's what we did. And really, this is the first, what we hope to be kind of the introduction to this line of inquiry, and really to think about what are the types of things that we're able to see by using this kind of lens of EMS quality measures and looking at it at a large scale.
I think that's so important, Dr. Berliner. And I was really impressed reading your paper. I was really happy that in the introduction you included a history of where quality measures have come from, because I think we all think to our agency, and the dreaded response time seems to be the one quality measure that we all track and we all spend a lot of time thinking about, talking about, discussing, and trying to improve. But quality measures are fairly new to EMS. In the last 5 years, we've really seen an acceleration of what matters beyond the dreaded response time.
Or
but
out of
there
shoot
have been-
times. Like if I'm being measured and given feedback about how I did as a paramedic, it's how quickly I hit the button that said I was en route. It probably doesn't even matter how the GPS tracked me en route. It's just this ephemeral measure of time intervals. And I absolutely love that the continuation of what Compass started is really evidence-based, and it matters to patient outcomes. So I think I'm pretty passionate about trying to get away from just counting beans and really getting to what matters to when patients survive. And if we're a system that's seriously about patient care, then patient care should be the outcome, not necessarily other surrogate measures, which sometimes matter and sometimes don't.
I think that's really important, and maybe a segue into how does a quality measure become a quality measure? How do we establish these benchmarks? Because I know NIMSCO just published some new ones, maybe 2 or 3 months ago. Maybe Dr. Leonard could tell us, how does a quality measure become a quality measure?
Oh, that's a good question. I mean, listen, I could probably talk for many hours about the work that we do at NEMSQA. But it's, again, it was started as a multi-organizational effort to bring together many stakeholders in EMS to talk about what mattered to us as EMS providers and medical directors and frontline leadership and national leadership, to really kind of hone in on what we think matters to patients. And again, that has to do with bringing the evidence and making sure that that you are creating measures that really matter, right? Because you could create a measure about like how long it takes you to put your electronic pen on the pad and then write the note. But that's not what matters. Now, it doesn't matter to patients how long it takes you to document. It doesn't matter to anyone else. Anyway, so we look at a few things, and it's a very standardized process that we've adopted in order to essentially create a reliable measure. And so we look at the evidence base. We look at its ability to be measured within the context of NEMSIS or another system ultimately, but and whether or not it work. You have to test it to make sure that it's reliable, and you have to understand what it's trying to measure and capture, and that it has kind of at face value something that is meaningful to everyone. And again, like Dave just suggested, part of the idea of creating these measures is giving people an alternative to rely on. So we need to create something that's reliable, so that people can actually be able to implement it. It's not a research paper. It's something that needs to be implemented in the real world. And so that's the stance that we take. And there's lots of information on the website that people can access if they are interested in the details of that.
I think that's so important. And what I keep hearing is it's patient care related. It's actually trying to improve patient standards. It's an alternative to the we got there within 10 minutes. Well, does that really matter? Not for most patients. There's plenty of data that suggests that. But giving the right treatment to the right patient in the right amount of time that's feasible and reliable, and also probably can be applied consistently across one agency to the next, to the next, to the next. So I think that's so important. I want to cue up Tony, who's going to walk us through just a little bit of the methods now that we've got an introduction of why this matters. And then we'll get into the meat and potatoes of the results. Dr. Fernandez, it's all you.
Thank you. And thank you, Dr. Redlinger, for joining us today to discuss this paper. I think it's going to be great to get this to a broader audience, because I know particularly some of the folks who are on this call are likely in paramedic programs or EMT programs and may not have been familiar with the NEMSCO measures. So Dr. Redlinger, if you could just come right back on camera, me and you will have a little chat here about your methods. And really, I want to start with your study aim. You aim to describe national performance from the NEMSCO quality measures in a national EMS data set at the individual level and at the EMS agency level. And I thought this was really important and novel to run the analysis two ways. Can you talk to us a little bit, not so much in depth about the statistics, but why did you think it was important to run the analysis on these two levels, the response and the agency level?
So yeah, thanks for the question, Tony. So I think, again, as the first time that we're doing this work, we wanted to provide a couple of lenses for people to think about the quality of care that's being provided. And so, I think one, we looked at kind of just the general performance. So in table 1, it's not only the listing of the measures. So just as a little background, there's 10 measures that we looked at out of the 11 that were the original NEMSCO measure set, because weight is not part of the national measure set. So we had to eliminate the pediatric measurement and weight as one of the measures we looked at. So we looked at 10 measures, and we first looked at them overall performance, and that's in table 1. And then we looked at it. So then we looked at urbanicity. So we looked at, kind of looking at environments or geography which had predominantly urban versus predominantly non-urban environments, and we looked at them comparatively. And we also looked at size. So we looked at kind of compared the size of the agencies to one another. And then on an individual agency level, we looked at kind of we used something that Dr. Jeff Jarvis, I think Dr. Henry Wang used also, but we call them pancreas plots. And they're the kind of a pictorial representation of the distribution of agency level adherence to the measures. And so we could show that in just a moment, but what we're looking at here is table 1. So one thing I'll note is that the total runs in each of the measures was different, because the number of, like, for example, pediatrics O2, kids suffering from asthma who get a call, there's only 20,000 of those that were represented in the NEMSIS data set. And so the denominator was 20,000 runs. And then the national performance of treatment with a beta agonist was at 61%. In contrast to something like Safety 01, which is the percentage of EMS responses originate from an emergency or 911 request in which lights and sirens were not used during the response, right? Thinking about safety and not using lights and sirens, because we know that it's more dangerous for providers and patients when lights and sirens are used, especially unnecessarily. But the denominator in that is 26,501,000, which was all of the responses that were in our data set. And so every ambulance had to denote whether or not they use lights and sirens. And so if you look at the number there, it's 11%, 11.5% where lights and sirens were not used. So that means almost 90% of EMS runs use use licensed sirens on their response.
Yeah, and I think that I want to really commend you and NEMSQA for really making these measures user-friendly. If you go to the NEMSQA website, you can download I believe it's the technical document, right? Where you can get not only just a description of the numerator and the denominator, but you can get pseudocode if your vendor doesn't calculate these for you, they tell you exactly how to calculate them, and including exclusions and the like. In terms of, I know all the work that goes into this, not just making these evidence-based, right, quote unquote evidence-based, but to get the information out so people can actually use that. Can you talk to our audience a little bit about some of the work that went into not only making sure that you can call these measures evidence-based and look folks in the eye with a straight face, but also being able to craft your technical documents in a way that it can be used by the masses?
I think one of the important things about the NEMSQA work is that we collaborate with a broad range of experts in putting together these measures. So we have measure development experts. Kelly Burleson is our measure development expert, who has helped really to kind of create the backbone of NEMSQA measures. And we have experts from all over the industry to tell us about how you match up an idea like a quality measure with the technical specifications of the way that we document EMS care. And so through the NEMSIS system, there's lots of, I should say, maybe I'll not say lots of, but to me that it seems like there's lots of very detailed things that happen in the background that are really important about how data gets presented and discussed. And Tony, I think your team can tell us all about the details of what happens in the back end, of any PCR system. But what I would say is that we looked at those and matched those up with the ideas that we were trying to achieve. And that technical specification, while there's many elements to it, right, from the moment you enter some information into the PCR to the moment it gets processed in any database, there are details about what's happening in the background. But the idea of these measures is that they take those specifications and create the numerator and denominator of what we're actually trying to look at.
Yeah, and that's great. And everyone on the call or listening to us right now, I'd recommend you go to the NEMSQA website, check out those documents, check out the numerators and denominators. It's really, really user-friendly and some great resources there, particularly if you're starting any of your own analyses. So back to some of your analyses in this paper, I really thought it was interesting how you went on to define kind of your underperforming agencies and your high-performing agencies. I think that kind of helps guide folks, particularly maybe some of the graphs that we'll get into when we talk about results. We'll take some explaining for folks who aren't as familiar with research, but I think the idea of overperforming and underperforming or high performing and underperforming is really important in our field. Can you talk about kind of how you went on to define your high performing and your underperforming agencies?
So I just want to give a caveat to our listeners, which is that underperformance and overperformance in this study are not traditional benchmarks or things that we're aiming for. This is really a descriptive way to look at agency performance across the country. And so if we look at our figure 1, we can see that there's different configurations of the way that each measure looks, and the shape of the curve has a lot to do with how kind of the distribution of how agencies performed. And so we're looking at the trauma 01, for example, and trauma 01, the performance that we're seeing is right. So the underperforming agencies are on the left-hand side, right, and we kind of go from performance achievement on the left, the lowest to the highest on the right. And so when you look at the distribution, you see any of those kind of like dots that are in red, those are the agencies that don't cross their score doesn't cross the median, their individual agency score, and the confidence intervals don't cross the median performance of all agencies. And so, and in the middle, there's the blue dots, which are kind of the ones that are, within the range of the median. And then the green dots on the right-hand side of each of these graphs are considered overperforming, meaning that their confidence intervals of their performance are above the median of the kind of performance of all agencies. And so, depending on how well this measure performs among all agencies, it will give you to, it will get you to either underperforming, overperforming, or in the middle.
So can I jump in and say,
Please,
just
Dave, please.
methods wise, one of the things I think about is what can I do as a field clinician to meet national goals, and trauma 01 is a great one to look at, because as a clinician, I can make sure that I'm asking a patient how much pain they're in and assessing their pain, getting a 0 to 10 scale before and after interventions, and treating pain, right? And as an agency, which if I'm a field provider, I may not have a lot of effect on what my bosses make a priority and give feedback on and say, look, you did great at assessing pain and treating pain. And especially in the context of equity, let me shed some light in the eclipse moment that inequity is an issue, and particularly addressing pain was an issue. And we've seen papers by Dr. Crow, who's currently in the dark. She's very enlightened, but currently in the eclipse. And the concept of me as a clinician assessing and treating pain is not necessarily what we're capturing here. It's whether or not my peers in an agency that reports back to NEMSIS, out of thousands of agencies that are part of NEMSIS and documenting patient care electronically, that we as a whole do not seem to assess pain. So the analysis that you, as you sought out to kind of look at this, you looked at it more from the agency, how much of this is being done. And in some of the cases, trauma 03 is up here too, and that's really the pain score was lowered during the encounter, and so the curve here reverses, right? And one of the things you discussed here real quick was the confidence interval and how many people were within the confidence interval. So just for folks that are not familiar with the research, and Tony will keep me honest, but the confidence interval just basically means how tight, how reliable are you at doing that measure, okay? So if you're within a 95% confidence interval, it means you're doing that measure a lot. So agencies that were in green were doing that measure a lot. Is that a common person's explanation for we met that performance criteria?
So I'll jump. I think that's a good explanation. I think for simplicity's sake, for folks who are on this call who aren't familiar with 95% confidence intervals, for simplicity's sake, think about it as this. If you were to run this test 100 times, right? The percentage that we found in those 100 times would be within this 95% confidence interval 95 of those times, right? So that's how confident you are in these measures, right? There are some technical things that we can get into why that there are caveats to that, but think about it that way, and that'll help you understand these 95% confidence intervals. I think one thing that's important before we dive into the results, because you did an agency level analysis here, and there were agencies who were high performing and underperforming. If I am out there reading this paper and I know that my agency submits to the state, which then submits to NEMSIS, and you just labeled my agency as an underperformer, how am I going to know? I don't want my name out there in a paper that says that I'm an underperformer. Can you talk to us about how that was alleviated in this study?
Yeah, so the NEMSIS research data set is very careful not to identify individual agencies. They have agency codes that are not associated with geography. It's like not listed. So this is non-identifiable data, right, from an agency level. So I couldn't pick myself out. Look, I would say that my agency is all the way on the right. They're in green and they're like, high performing
Of
in
course,
all of
yes.
these. But no, you can't really tell who it is, and the way that this is, I think the methodology of this kind of visual representation of agency performance is definitely I would credit to Dr. Jeff Jarvis in this study, kind of giving us the way that he's done it in past studies related to other conditions or specific conditions. And so I would just say, like, if you are, let's just pretend for a minute, right? I know we just said that it was de-identified, but let's say you knew which point your agency was. And if you were in the red, like on the left-hand side, and your performance was at 10% of trauma 03, you would find yourself somewhere on the line. So that means that only 1 in 10 patients with pain are you treating effectively, or decreasing their pain,
or documenting, right, that you're doing it
documenting
effectively.
decreasing their pain score.
Yeah.
Right. And so which brings me to another subject where I'll get to in just a moment, but right, that's not great performance. And even if you look over to the right in trauma 03, that you're not, even the higher performing agencies in this measure are only somewhere near 50%, or maybe there's a few that are up near 75, but still you want to see that that's not a benchmark. You want to see that the pain is treated and you're affecting change in a patient in a much higher percentage of people that you're treating for pain in trauma. And so Tony brings up a great point, which is that this is any time that you're looking at statistic measures within EMS, or probably within medicine in general, it's part of this is the way that we document and capturing the actual care that we're doing. And so it's sort of like a demonstration of how important it is to document well and to make sure that, and to have all of the people who support your documentation, make sure that the documentation comes across in a positive way. But it's also about, knowing where you are. Once you fix the documentation, like, where are you? What's your performance really like? And so again, I think that these measures, we acknowledge that these measures are a combination of the reality of documentation EMS and the actual performance. And so it's hard to tease that apart. And I think we're looking for ways to really get to the real data, but we wanted to start somewhere. Because that's
absolutely. And just that you're giving this back to the field, hopefully this is kind of an impetus to make folks pay more attention to their documentation habits, because they really are being used to impact change in our field. Now, I always have the unenviable task of holding folks up from getting to the really interesting results, talking about methods. But before I open up the floodgates to talk about results, I just want to open it up to a couple of our other panelists to see if they have any methods-related questions. I see Michael Caduce is up on the screen. And I just want to, again, thank you and commend you for writing this paper. And I'm interested in going over the results.
Thanks, Tony. I just had one question. I think it's worth recognizing that most of these measures could be completed by any agency, ALS or BLS, for example. Assessing a pain scale can be done by an ALS or BLS agency. Splinting, ICE, things like that can all be used. Distraction can all be used to lower pain scales. Was there any account taken into whether an agency is ALS or BLS? I'm thinking about the one that requires benzodiazepine administration for a patient having a seizure, recognizing that most BLS agencies across the country would be unable to meet that standard.
Yeah, it's a good question. And I think part of, right, this is a question about how do you design measures, right? And it's not necessarily related to the study specifically, but right, you see, well, one thing I'll just say related to the study is that you see that the number of cases that of seizure 02, it's 79,904 patients that are calls that are involved with this condition. And there's a couple of things. So, right, so if I am a patient, I don't really care if I get ALS or BLS. I want to know that I'm going to be taken care of. And so it's not a critique necessarily of a BLS agency that they didn't give a benzodiazepine, but it's a recognition that any patient who's having a prolonged seizure should get a benzodiazepine at some point. And so if you are in a system that can't get an ALS provider to a patient having a seizure, there's something that you should be thinking about. You know, the decision makers in that area should be thinking about how to kind of make a change so that you might have an ALS provider to provide the care that's needed to a patient.
I think
And that said, I mean, like, look, if I'm the leader of a BLS agency and I say, oh my gosh, 0% of my of patients taken care of by my agency are getting benzodiazepines, it's not going to be surprising, right? So again, I think that the point is not to be critical of individual agencies that don't provide the level of service that are needed for a specific measure. It's not a critique. It's just, it's just kind of like, it's an understanding of the way that EMS works in our country, and we want to create a system that has access to the right treatment for patients. So it's not, again, so we looked at it both ways when we're creating measures. Like, we want to inspire the system to get better, and we want to help agencies measure what is important to them. So not every measure is going to be important for every agency just for those specific reasons. The other thing I would say is that, right, we're not aiming for 100% in every measure. So the fact that this is 26%, I don't know what that really means, because, we debated this for a long time about what does it mean to have status epilepticus, right? And like, we tried to kind of create a proxy for patients who are still seizing when EMS arrives. And so it's not going to be true, right? If somebody gets a diagnosis of status epilepticus, it may or may not be true that they're seizing when it's time to give medications.
Mm-hmm.
So I can't, right? I am very humble in the fact that we can't predict everything, but in the way that NEMSIS is created. We can't decipher every clinical situation. But what I do know is that it should be looked at in a way that we want patients with seizures who are having active seizures when they have when EMS gets to their side, that we want them to get a benzodiazepine. And so creating a measure that kind of, that states that this is the standard, I think is important. And we probably will never get to 100%, and that's okay, right, from a patient treatment standpoint.
Absolutely. I'm going to give Jeff a sec to jump on so that to share the results, but I think that's really important, and it makes me think that in a hospital, for example, if you show up at a level 3 or 4 center and you're having a STEMI, we don't just leave you and say, sorry, this is all we can do for you here. We work to get you to the place that can help you the best, right? And so I think there's a lot of validity, or that should be sort of spinning around the heads of our listeners, like, oh, actually, that should be a goal, right? It should be to get an ALS provider there at some point in time, sooner the better, but recognizing that how you can apply these standards to your agency, some may apply much more than others. And I always like to start with the low-hanging fruit. So there's probably some of these, a benzodiazepine administration in status epilepticus for an BLS agency, that's a pretty high level task to take on, but almost all the rest of these would not be. Simply documenting a stroke scale in a patient suffering from a stroke is not a high benchmark to meet. To me, that would be the low hanging fruit, the things that we could take on immediately to try and make sure that we were, meeting the threshold at least a certain percentage of the time. But that's a pretty easy one to be at 100%. But I think that's so important for our listeners. If you don't have another comment, Dr. Redliner, we'll start in on the methods, but I want to open it up and if you've got something else.
No, it's real. I mean, I would just say it's important. Like, again, every pediatric patient should have a respiratory assessment, right? And so there are things that should be 100%, right? In our new set of measures that are not part of the study, waveform capnography, airway 18 is a great example. It should be 100%. Every patient who has an advanced who has an intubation should have a waveform capnography. So each measure, we don't compare them to one another, right? Because each one is a little bit different, and there's some subtleties around what success means.
I think that's so important. Jeff, I've got table 1 pulled up and I've got all the figures copied in. If you want them, you just tell me and I'll move us to the next one.
Sounds good. Thanks for pulling that up. And Pleasure to be on with you, Dr. Redliner, and to see your excellent research. I know there was a lot of work that went into this, many years with creating these measures and the EMS Compass and MSQA. So it's really amazing to be able to actually see this applied to that national data set. So kudos, and want to commend you on this really good study. And you did a really nice job kind of teeing this up, explaining how we got this. And then just before we jump into results, one quick thing about methods that I wanted to point out was that this is a very inclusive data set with NEMSIS, and that it looks not just at transports and ambulances, but total responses. Some of these metrics are only transports, but we know that a lot of EMS is delivered by first response agencies, that the fire department might be a BLS or ALS provider. They get there, they might have a good 5, 10, 15 minutes with that patient until the transport ambulance gets there. And we want to make sure that they are getting that respiratory assessment done while they're on scene and not just waiting for the transport ambulance crew. So I know we have a lot of EMS providers that can be in different systems where they're not necessarily transporting. So I think this is great that this data set looks on both sides of that. And then as far as our table 1, so you provided very succinct, clear explanations of what exactly each of these 11 measures are, and then the 10 that we're looking at. Of course, we don't have, unfortunately, recorded weight data in NEMSIS, so we're not able to look at pediatric 03B, but we can see that these runs, some of them, one of the measures, safety 1, for example, incorporates every single EMS encounter, since there's always a response involved, whereas others are much smaller. So it ranges to pediatric 02, about 20,000 responses, so less than 0.1%, where it's a patient that would have requests for diagnosis with asthma, and then whether aerosolized beta agonists are administered, whether they get albuterol, essentially. And we see that we have this huge data set, so over 26,000 responses in 2019 from almost 10,000 EMS agencies, and that big variation in sort of what is included depending on the measure. And we have that overall run level performance, which is that really quick snapshot. But I know that you were very interested, Dr. Redliner, in kind of breaking this down, since that surface level, run level performance doesn't tell us as much. So if you could just explain to us some of the different categories that you broke this down into, and how you tried to compare agencies that were maybe more similar to each other.
Sure. So again, I think that the overall picture is interesting, like you said, and I just a couple comments about the methods in this. So the data set, I don't have it off the top of my head, but it's a little bit larger than this. It includes non-emergency calls as well. And so so there is, we pared down the data set for only 911 or emergency type calls. And again, like you said, I think that we have select data for each of these, and that theme kind of permeates the rest of the study, right? So if we're looking at each of these, whether it's urbanicity or the agency size, I think we could see, again, this is a common theme, and so we'll see that throughout. I don't know if you want to go to table 2 or.
Yeah, sounds good.
So table 2, we looked at, right? We used kind of this a structure that was based on a study that we did a number of years ago that looked at, it was more of a survey-based study that looked at the differences in how people are using measurement. So we weren't able to look at the data set, but we did publish in PEC, I think it was 2018 or something, that it was a national survey. So we used the same agency size structure in order to look at the quality measures and each one of the quality measures. And what I would say about this analysis is that there's a lot of variety in agency size and performance. And let me see if I can pull out some specifics, but the smaller agencies are on the top. and the larger agencies are on the bottom, right? The greater than 100,000 total calls. There's fewer agencies that are that size, and there's many more obviously that do between 1 and 1,000 calls, or 1,000 and 5,000 calls. And so that you see that there's a gradation of performance that, like for hypoglycemia 01, right, the first column there, you see that the smaller agencies have a 60% performance, and the larger agencies have an 82% performance. There's a difference, and actually, the statistical calculation in this table is, we don't have all of the like the p-values here or the comparative values here, but this is just kind of a straight up this descriptive table of what agency performance looks like, and I encourage people to look at this more specifically. If you go to the urbanicity table, which is table 3. Now, this is a little bit probably easier to kind of look at visually and to see the difference. We have the p-value on the right-hand side. So urban agencies, meaning they had a greater than 50% of calls in areas that were considered urban by common standards in research. There's specific elements of it. Maybe somebody on the team, Tony, maybe also Jeff, I don't know if but anyway, there's some certain criteria around urbanicity. And so if, like, again, if more than 50% of an agency's calls are within an urban area, then they were put in the urban agency bucket. And if there was less than 50%, they were put in the rural agency bucket. And so, we can argue about the artificialities of that, but for comparative sake, it's a one way to do it and to look at the two different types of groups. So there's some here that have a significant value. They have a p-value that's less than 0.001, less than 0.05. And so, but you'll notice that the performance isn't really different. And those are like statistically significant, but probably not clinically significantly different. But there are some of these measures, for instance, like safety O2, which is transport from the scene, non-lights and sirens. And so in urban places, in urban agencies, only 50% of agencies go without lights and sirens. And in rural agencies, only 21%, the performance is 21%, the median performance is 21%. So that means that that the agencies in general at the median transport over 75%, 79% of patients, lights and sirens to the hospital. And so that's a lot more than we would expect and we would hope for, right? We, in other projects that we've done, in other studies that we've looked at, I mean, again, Dr. Jarvis and Mike Tegman and a number of other folks looked at the number of critical interventions that could have benefited from a faster time to the emergency department, and it's somewhere like 7% that required immediate intervention at the hospital. So, in an ideal system, you might want to get to 93% of performance in this, but we see that in rural places that there's lots of lights and sirens use.
Yeah, thanks for pointing that out. And definitely we see a lot of variation. If we could go back to table 2.
Can I just want to insert here, it's a hard sell. I once heard Ron Stewart say, one thing is to not spinally restrict or immobilize at the time 90% of the patients, because they really 90% of the time don't have a spinal fracture. But if it's my daughter and she broke her neck and you don't immobilize her, then by golly, I'm going to be really upset if she's in a wheelchair. And it's that 1 point, or whatever, 0.1%, 1%, doesn't matter. It's that moment. And it's a counterintuitive thing in our culture right now, particularly when it comes to lights and siren, to say, okay, actually the goal is to not go lights and siren. The goal is counterintuitive, because we think, well, no, we should really it's the right dose for the right people, right? The right dose of the right drug, the drug being lights and siren, has to be applied correctly. Otherwise, it is lethal and will, cause crashes and people injured and patients dying, as well as providers. So the mind shift here is we really want to be measuring that proper use of that quote unquote medication, which is lights and siren in my dosing analogy. And it is a hard sell to go, you should be, by performing well, you're actually reducing the number of lights and siren responses. But I wanted to call that out because as we think about what makes a good EMS system or a high performing EMS system, it's actually it's really counterintuitive when you bring in response times, which is the whole reason why the topic of this podcast and journal club was really about not just measuring how quick we get there. And it's going to be really culturally a sell to the public as well, that though I perceive this to be my own emergency, it's not. And how we shift the system is actually really important. So just that deeper dive into what makes the care really great is really actually culturally going to be just as important as how we measure it. And I hope we can measure the patients that really actually needed lights and siren, if that was really the case, and 3 minutes or 7 minutes or that little tiny savings was really going to make a difference, can be just as important as the overall you stopped using something. So measuring the negative, I guess is my comment.
I mean, again, the debates that took place around how to set up the measure and the measure specifications were epic because of that question ultimately. But what we ultimately decided was that we wanted success to be higher, and we think safer care is without lights and sirens in general, right?
Mm-hmm.
There are those cases that probably you want to do everything you possibly can to get the patient quickly to the definitive care. But on the whole, that it is more dangerous for both patients and providers to go to the hospital to go lights and sirens in general. And you're like, it's the risk benefit analysis, right? If you have an ankle injury and you get into a car crash and you get severely injured or killed, it's probably you would understand that justification. But to your point, I mean, it's a huge shift in EMS to think about dialing down the lights and sirens so that it's safer care, because you feel like you're getting there faster, you feel like you're going to do something more quickly for patients, but the reality is that it is definitively less safe to go lights and sirens, and so you want to use it in a rational way that fits with the evidence that we provide, and that we have a whole project based on lights and sirens use and improving our safety in EMS with NEMSCO as well. But that's another story.
Love it. I think when you look at the results of this, it's one of the sort of stories about this, which is that if 11% of that, denominator is actually, meeting that goal, there's work to be done in that area. Not to mention, I mean, definitely pain and treating hypoglycemia or stopping a seizure, to me, are the some of the basis of what we do every day. But that lights and siren one just pops out like.
So Dave, if you'll indulge me for a moment, if we can go to the figure with lights and sirens. So there, go back. Right, exactly. So I'll just say, right, safety O2 is transport from the scene, lights and sirens. So this is, right, the agency level performance, and the kind of like the lower performing, followed by the median, followed by the higher performing, right? And so you see that individual agencies, right, all the ones that have that are green all the way to the right are near, they're probably in the mid 90 percentile wise. And right, if I'm talking about benchmarking or thinking about excellence in EMS care and safe care, I'm looking at those agencies, right? And so there are different agencies at different stages of performance related to this. As you see all the way on the left, there's a high number of agencies that are just all lights and sirens all the time. And so when you look at like the overall national performance and you think about how you're going to, improve it, your strategy for this might be different, right? Because there are some agencies that that use lights and sirens all the time. So your strategy is going to be different than for those that are in the middle. And you can talk about, dispatch codes that you use lights and sirens for, and not like there's some that are just a full cultural change, right?
Right.
Maybe you shouldn't use lights and sirens for everything. And there are some that are, let's talk about how do we differentiate which we think are going to be emergency and which are not. And there's a lot of science around kind of attaching lights and sirens response to dispatch codes. And so,
well, and even down to the nitty gritty of not just perception of actual contracts where a provider might have to meet a certain response time and they're just, not there. The measure doesn't matter if you can't maintain performance according to the either local government contract, if you're a private provider, or if you're a public provider, the perception of the city council that says you're just not responding. So some temporizing measure of advice and downgrading and explaining might. But you're right. I think that it's different sizes for different folks in order to be able to get at this. But until we have a dashboard, I think Dr. Heather Davis is great about saying this. Nobody watches their speed limit until they see the police car in their rearview mirror. So unless you have some sort of ability to see what it is that we're trying to measure, it goes unnoticed. It's just part of the way that people explain, what they do. So kudos to you to try and begin that visualization.
Yeah, and look, these are the exact types of conversations that we hope to inspire, right? Like instead of talking about how fast you got there and meeting that goal, like we set that goal up many years ago because that's what we had. And now the idea is that we have other things to look at. And there's going to be a national position statement, like multi-organizational position statement, looking at a balanced measure set for EMS. And clinical performance is part of that. And I think that's the exact type of message that we need to to get to those details. People want to measure performance, and it's natural for government agencies to say, like, well, tell me how you're doing. And you say, well, I can tell you about lights and sirens. I can tell you about my response times because I can measure it. Right.
Yeah.
But now, like what I hope this does is it gives another barometer, another scale to measure success on, right? And by providing that scale that people can rely on, then they can have it and use it as opposed to using just the response.
I'm waiting for the big disruptor, and I know our time is short, and everybody has to go. I'm waiting for the big disruptor, the Uber disruptor, where literally Uber, like you called taxis and you waited for them to just show up. And now you can give feedback to your Uber driver, and Uber is paying attention to everything, including safety, but just even how clean the car was. And we need that system level change that says, I didn't just hit the Uber button and got Uber Eats, a moped. I needed an extra large van to carry, my wheelchair, and we have to reach a systems level change where we measure these quality indicators, and the public is part of that. Otherwise, I think we're just going to be spinning our wheels trying to go against some of the impressions that have been in common culture, like television and ambulances screaming down the street, and then the person who gets there doesn't even know how to stop the seizure. So,
In the last 5 minutes that we all have together, I thought we might dive into our discussion and see what our panelists had to say about the overall discussion of the argument and where we go from here. What does this really mean? What's the true takeaway? A couple of things that really struck me about the abstract was this is the first time we've looked at this type of EMS quality measure set in a national data set. That should be a little bit exciting and maybe a little bit concerning. Some might say it's eclipsing that we get to look at this data set, but it's taken us a while to get there. I also want to provide some inspiration for the agencies that are out there saying, gosh, I wonder where we fall. There are agencies that are doing this, that are achieving sort of the near perfect or perfect measures. They're meeting these every single time. And I think that's really important. The third takeaway I had, and then I'm going to open it up to our panelists to share their takeaways and Dr. Redlander to sort of like give us the end all be all as we take it away. At least half of agencies demonstrated documented performance below 35% of the time in 5 of the 10 measures. That gives us a future, and this paper gives us the blueprint to follow to say, gosh, where are we? Can we apply the quality measures to our agency and start improving it? There's a whole quality improvement science we could get into, but in essence, there's plenty of room for us to get better and to grow. Dave, Tony, Jeff, Bill, any final thoughts?
I was going to thank you again and say that you're really making the case for what gets measured is what gets done. And if we don't measure something, we don't know about it and we can't improve it. And this is really, I mean, I know it took a ton of work just to get here, but this is really the start when it comes to quality improvement. We have to know
keep going, right?
Exactly.
Keep going. Don't stop, because the measures,
Exactly.
you know, these are 11 measures. I can think of measures like stretcher drops that are really hurting patients and providers that I hope we, you know, get at as a quality measure, like quit dropping stretchers, quit, you know, other elements that I think we need to continue to expand that based on evidence. And I'm excited. You have PCRF at hello when it comes to partnering with NEMSQA and getting some more evidence out there that says, you know what, we've looked at it, and really this is what really great ambulance services should be doing, or really great clinicians. This is good patient care.
Yeah, I'll just chime in on that and say, you know, congratulations. This is a great paper. I think it's going to do wonders for our field and the assessments of national quality measures. So yeah, to echo what Dave was saying, keep going. We can't wait for the next paper on the 2023 measures. And yeah, thanks for all the great work you do.
I'll just say that it's a collective effort. There's a lot of people who are involved with this. And honestly, the collaboration of it all to get to the right answer for the industry and for the community at large, I think has been really impressive. And so, you know, I get to sit here and talk about it, but again, the work of so many people has gone into getting to this place. And so, you know, I'd just like to thank my co-authors for all of their collective work. And so it's been a lot of fun. And I think hopefully this is, again, like I said, this is the beginning of the conversation. We'd love to inspire a whole new generation of people who are looking at quality, you know, these quality measures and how they're changing over time and how we're demonstrating improvement.
Definitely takes a village. So great to hear that we're definitely moving in that direction. And was just going to point out one last thing, that what I really like is that these are all process measures that can be directly affected by EMS providers themselves. I know we like to think about outcomes. Did that cardiac arrest patient survive or not? But there are a million different variables and many we cannot control. But everything that we've discussed today, these are all things that are generally within the EMS providers' line of control. So I think this is an excellent place to start, and really looking forward to seeing what comes next now that we're able to measure these.
Well, I want to take a big shout out or time to thank our panelists, Dave Page, Dr. Tony Fernandez, Jeff Rollman, Bill Toon, and most importantly, Dr. Redliner and his entire team for publishing this paper, really providing some great insights into our EMS operations and our agency operations. If you liked this podcast, please join us April 26th for the PCRF Education Research Podcast. That's at 10 a.m. Pacific, noon Central. And the next clinical podcast will be Monday, May 13th at 10 a.m. No eclipse next month, so we look forward to seeing you back here. Thank you so much for taking the time out of your day to join us for the PCRF podcast.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.